Good morning and welcome to peripheраlinterventions.org. Today is June 24th, 8 o'clock Eastern Standard Time. I would like to thank everyone who was in our last week's CCVCC symposium. And today we have an interesting case conducted by Dr. Prakash Krishnan. Dr. Krishnan, good morning. How are you?
Good morning, Dr. Wiley. How are you? Welcome to the Cath Lab. I'm here with Dr. Vishal Kapoor, Dr. Bhaskar Purushottam, Ray Lascano, and we're here with our team, Elizabeth and Ricky, our outstanding cardiovascular tech. So I wanted to just present a wonderful case that we're hopefully going to try to get done in an hour, but at least we'll try to do our best to teach all the concepts that we want to get across. And I want to go ahead and ask Bhaskar to go ahead and present the case and Vishal to talk a little bit about our plan. Go ahead, Bhaskar.
Can you put up the slides, please? Yes, so today we have a 68-year-old man who is an ex-smoker who essentially presented to an outside hospital initially almost a couple of months ago with right lower extremity critical limb ischemia. He had a right fifth toe gangrene and he had a lot of pain. So he underwent an intervention there where they opened up the right popliteal short CTO. But after that, he still had significant residual infrapopliteal disease. He did not have a single vessel which had a straight line flow uninterrupted all the way down to the foot. One of the reasons they stopped was because he was a chronic kidney disease stage 3. So then because of persistent pain, he went ahead and had a right fifth toe amputation at the outside hospital. And as he was almost 3 weeks post-op and his wound was not healing, and the guy continued to have persistent pain, he was transferred to our care. He also has a history significant for coronary artery disease, myocardial infarction, multiple PCIs. He has ischemic cardiomyopathy with an ejection fraction of 30% with a ICD. He's also, as I said earlier, CKD stage 3, hyperlipidemia, hypertension, diabetes, and GERD. His medications are aspirin, Plavix, Coreg, Lipitor, enalapril, and a few other pain meds along with his PPI. Next slide, please. So his vital signs this morning were stable. His pulses on the right side were kind of faintly Dopplerable. And then we'll show you a picture. Can you go to the next slide, please? So this is a picture of his right foot. And as you can see, the right fifth toe is amputated. And that's the surgical site, which is not healing, which has got very partial granulation tissue. And therefore, we brought him back to the cath lab to see if we can open up and improve his flow. Dr. Krishnan?
Now, thank you very much. I'm going to have Dr. Kapoor just go over the angiogram. Go ahead, Vishal.
Sorry about that. Okay. So here this is a patient who comes in, like Bhaskar told you the history. You can see this is the right leg, distal SFA popliteal with a runoff. We fixed his popliteal last time. The patient still persisted to have this ulcer, so now we're going below the knee for the intervention. The popliteal is still patent, and if you look below the knee, the AT is occluded proximally with some collaterals. The TP trunk has some disease, but it's not bad. And we'll see you the next shot. Here again, so like I showed you, proximally there is AT which is occluded, which forms distally via collaterals, and then it goes down all the way through the DP. So with his distribution and his location of the ulcer, we decided to intervene on the AT part. So now going for the, like Dr. Krishnan said, let me show you one more picture. That's a better picture, give you a whole idea. So there's TP trunk disease and below the knee disease as well, but the primary goal is to go after the AT and see if we can have direct revascularization. If for some reason we cannot do it, then we'll go the indirect revascularization based on the angiosomes.
Yeah, but ideally speaking, if you look at the territory that this particular vessel is involved, or the ulcer is involving, it's likely going to be the posterior tibial distribution with the lateral plantar artery, as you know. So unfortunately, in the foot, we really pull back a little, Ray. We really don't have a lateral plantar artery in the foot. So therefore, now we're trying to figure out, whether we can at least get one of these vessels open. As you can see, I'm out of the vessel there. So the point here is, what can we do to try to get this open? So right now we were down with a fielder wire. So our technique here is to go ahead and put a 014 system and upgrade to an 035. Obviously, the foot vessels are very, very poor. So as far as being bypass targets, they're not going to be very good. But clearly, we need to improve our inflow, and we felt the best target here is going to be our anterior tibial, just because of the distribution, the fact that we have a nub to get into, the fact that it is occluded, but it seems to reconstitute, and seems to have a little bit of play for us. Track it, Ray? So we can see here you have a calcific, the creatinine is high, so our plan here is to go ahead and try to do a two-step approach. Hold on, Ray, let me see where this wire is going. So our initial plan is going to be to attempt an antegrade cross of the anterior tibial, just the way we're trying now. And then if this fails, bring him back for a retrograde. And you know, part of the teaching of these cases is that you have to understand with a creatinine of around 2 at this stage, you clearly want to try to do a stepwise fashion of trying to get it done. So right now you can see this wire is tracking quite good, and it's really just a field thing and really sort of seeing where the vessel is going, and then kind of getting an idea of where the anterior tibial artery is going to run. I just feel like I'm a little too medial right here. So, you know, what we're trying to do is we're going to try to demonstrate an antegrade wire escalation technique here. And let's see whether we see any anterior tibial artery coming back. I can see some of the calcium.
So because your rationale of trying to intervene in the anterior tibialis is that likely the pedal arch may be patent and perhaps you may have a direct flow to the area of injury, correct?
Yeah, I think our first choice would be anterior tibial artery because we can see it. We can try to get into it. You can see we're almost in it. Kind of revascularization just to get direct flow. If I fail in this, then what I'm going to do is I'm going to try to go ahead with bring him back. I won't do it this hospitalization. Bring him back for a retrograde cross later on. I mean, obviously.
Would you have attempted that initially or not?
Jose, as you know, here at Sinai, we're so good. Our team is very well experienced with wires and catheters. You see, just sort of understanding which way the vessel is flowing, we're able to get through these kind of difficult lesions. Again, you got to really follow the process of how the wire behaves. Trust your instincts, and then take it all the way down.
Perhaps there's always a risk that when you attempt a pedal axis and you haven't tried from above, you could always injure the vessel, and then essentially you're done.
Well,
so
that's absolutely true. I mean, we would hope that, we wouldn't. And, but in these kind of cases, the options are so few that, it's probably reasonable to attempt it if you fail an antegrade access. Now, I'm going to try to have Ray track this down. Let's see what happens.
You got contralateral access. Would you have considered antegrade access?
Push hard, buddy. Contralateral access. You definitely think, in our conference, Dr. Graziano, we're prolapsing. Show me above. Nope, we're okay. You remember Dr. Graziani in our conference, how vehemently opposed he was to up and over accesses. Now, as you know, I was actually told his name has a French origin to it, and it's actually L'Enfroy, and I kept calling him L'Enfroy. So I want to apologize to him on air because I know he watches us all the way from Italy. But the truth of the matter is, I think that I think you should do what you're good at and what your team is good at. We've done tons of these cases, you and I, Dr. Kapoor and Dr. Guja, over the years with Dr. Dangas. And that basically this is our most successful approach. So I'm going to stop here and give a little dive, even though I don't really want to see where we're going. So yeah, we generally try an up or over approach inject, and then we decide what we're going to do afterwards. So right now we're trying an up and over. We're running into a little bit of a roadblock where we are. I may be a little dissected. I may not be. So it's important to understand the anatomy. You see right there, we are probably in the anterior tibial in an occluded segment right there. And you can see the anterior tibial slowly forms all the way down. So the issue is what you're looking at. You're looking at the posterior. You're looking at a couple of unnamed collaterals, and you're also looking at the perineal artery that's coming back. So I'm actually at an occluded segment in this area, and this is kind of going to be our challenge live. As you can see, we got up to this area.
Where are you seeing the reconstitution of the anterior tibialis?
I'm sorry?
Where are you seeing the reconstitution of the AT?
We're seeing it in the foot. I'll show it to you in a second. We're seeing it in the foot. Now,
So none of these vessels we're seeing right now are the AT.
Well, I'm not sure. I can't comment on that right now. But in my opinion, no, none of these vessels are the AT.
Okay.
Obviously there may always be a vessel that's there that's part reconstituting the AT. And I want people to trust their judgment and trust what they feel, but the key is you have to know, the general direction of the anterior tibial artery. And I know that's not the general direction, as you can see. Remember, there's going to be areas where you're subintimal, where you're out of the vessel. Do not worry about the small stuff. It's all wire perfs and everything. I never worry about stuff like that. Just go forward, trust yourself, believe in your approach to these patients, and then go for it. If you don't like where you're going, don't hesitate to pull back. Ray hasn't bought the catheter back.
What support catheter you're using?
We're using right now we've tried the Cook CSI. Right now we're just using a fine cross, okay. Which is a coronary catheter. Now to build on your story, what I'm going to do now is to look a little bit lower and give a little extra dive, which again is part of the reason why you don't want to go ahead and do too much injection.
Are you diluting it?
We're diluting it, but as you know, diluting is really just kind of makes us feel better. Doesn't help the patient any. So you can see I'm off. You see the anterior tibial is down? No, I'm not off. I'm heading the right way. Yeah. You see it's all the way distal? See where it is, Dr. Wiley, how small it is?
I'm not sure if I'm seeing it.
Well, it's all the way in the bottom. Bhaskar, do you want to show him where the anterior tibial is by pointing at the screen? Or actually using a marker or something? You can see it's a twig of a vessel, way distal.
Can you guys move the monitors?
You can just touch it. They'll show you.
I want to change my gloves.
Yep, you're going to have to change your gloves.
Is it this one?
Right, a little lower on the left. See, Dr. Bhaskar is having trouble too, right there.
So you want
a little lower, the other side. That's it. You see the twig of the anterior tibial?
Oh,
so that's the AT coming back in the foot.
How do I know that's the AT?
Okay, we'll take another picture.
I just don't want to trust Bhaskar.
Sure.
Yeah.
We'll take another picture for you on DSA, Dr. Wiley, just so if you see. And I think this is an important question that Dr. Wiley's asking, because it clearly, will let you know, what you're intervening on. So I want you to try to see the wire right there, right? And then we're going to inject right. Actually, let me go a little lower for you.
I'll need it.
Right there. Okay.
Roadmap?
Oh, you don't need roadmap.
Okay,
Yep, inject.
inject.
Oh, it's not DSA.
Hold on.
Can you see it there, Dr. Wiley, in the foot?
I do. I
So
see dorsalis pedis.
Yeah,
there.
so even though we mistimed our injection, you can see where it is. And it's quite a robust dorsalis pedis, so we will do that in our second attempt. I mean, these kind of cases need a couple of attempts. I mean, this is not an easy case by any means in anyone's hands, and anyone who says it's an easy case is actually lying to you. So the truth of the matter is you just need to work on this. And while I work on this, and you guys can put this next to Dr. Bhaskar, what we're going to do is we're going to work while Dr. Bhaskar has a nice presentation for you guys.
Can you put up my slides, please? Yeah, next slide, please. Yeah, so today I decided to pick this topic on retrograde approach to infrapopliteal or popliteal interventions. And it's a very brief presentation. So first I thought, well, let's clear up on a few terminologies. So when you hear a retrograde approach and you have essentially transtibial, so this is when you access the anterior tibial or the posterior tibial of the peroneal artery, kind of just above the ankle or at the ankle. And then you have the transpedal is when you get into the dorsalis pedis and into the arcuate artery. And then finally you have transdigital, where you actually access the arteries which supplies the phalanges. And then finally you have the TAMI, I'm sorry that's an extra I there, which stands for tibiopedal arterial minimally invasive retrograde revascularization. TAMI in the last couple of years has gained some interest. The reason being, especially if you have a patient who's morbidly obese, the groins are infected, or they have CHF and they cannot lie down flat, then the entire procedure is done through the tibial axis. Next slide, please. So what are the advantages of going from retrograde approach? So A, you got real small diameter vessels, so therefore your torque and your pulsal, your pushability and whatever force you apply is transmitted pretty much one-to-one. As the collaterals come off at an acute angle, there's less likely a wire is going to enter into the side branch. And next, we have the CTOs where the proximal cap is always considered to be the toughest to break, while the distal cap is much more softer. And then there's a shorter arterial segment to traverse, so therefore you have less problems as far as getting the balloon across or getting your system there. And then also, when the vessel size precludes the use of embolic protection device, then you can go ahead and consider retrograde approach. As I said, morbidly obese patients, hostile or infected groins. It also reduces radiation and contrast exposure, obviously less bleeding, and there's a higher incidence of luminal crossing. So when you read the literature, you'll see that there's not much data. There's hardly any randomized data, and most of them are case reports, or case series, and a few retrospective observational studies. So usually they say when you start to approach, you got to decide what will be your strategy. And are you going to plan to fix from the antegrade, or are you going to approach and fix everything retrograde, which determines the sheath size. So Cook has a very nice system, and I think we did show some of the techniques in our symposium. So you have a 2.9 French system where you can just pass 1.5 balloon and some wires. But if you want to do a CSI or something a little more aggressive, then you need a 4 French system. Next slide, please. So some of the disadvantages is these vessels are highly prone to spasm and dissection. And that's why they recommend that right from the local anesthetic to the time you access the vessel, you have to infuse a vasodilator. In fact, some operators give systemic vasodilators. And even in the lidocaine injection, they mix 50-50 with nitroglycerin. So therefore, even if they accidentally nick the vessel, this way they don't cause any spasm. And once you access the vessel, you go ahead and give intraarterial heparin. You go ahead and give your nitroglycerin and some verapamil. And it's important to note that some of these vessels are calcified. The fact that you're intervening on infrapopliteal vessels, it means they're critical limb ischemia, and therefore these vessels tend to be more calcified, as you see in diabetics and renal disease patients. So therefore, you might have sometimes difficulty cannulating as well as passing a sheath. And sometimes when your best shot is to get into the ankle, then there's usually a very sharp bend and you'll have issues passing your sheath. And then finally, you got to keep in mind that there is the risk of jeopardizing the surgical graft site, and also it probably might be the last remaining arterial conduit. So therefore, it's also important to acknowledge that after you access the vessel and you perform your procedure, you can have an acute closure, but also they can present a few days later. So that's something it's important to keep in the back of your head. Okay. That's it from me. Dr. Krishna.
So where are we now?
Well, we're working our way slowly down, as you can see, Dr. Wiley. You
seem to have done some headways.
We have definitely made some headways. The point now is whether we get tibial access and try to go up north may be the way to go. I feel like I'm a little subintimal. Show me a little lower, right there. Let's go one more mag lower for me.
You're so close that it may not be unreasonable to get access.
Okay, ready? Let's do tibial access. Let's do roadmap again. Inject. We'll give it a good college try, but I'm a little curious on your approaches and when you guys switch to tibial versus non-tibial, and then decide. So you can see we're heading in the right direction. We're clearly in a very, very good plane here. We just need to try to get over there if we can, what the good Lord has in mind for us on this Wednesday.
I agree with you. If you could avoid it, I think it's best to approach it antegrade. I use a retrograde access as when it's our last resort.
Dr. Riley, how often do you go axis, I mean, meaning from the ipsilateral side rather than going up, contralateral up and over. I know Dr. Christian talked about Dr. Granziano and his approach. How about you?
I'm sorry, you're asking me what?
I'm saying, how often do you go antegrade axis? You know, Dr. Christian talked
Yeah.
about Dr. Granziano going up and over contralateral.
Hardly ever. I would only do it if I cannot do it from a contralateral axis. A lot of times we get a good purchase by advancing a multi-purpose catheter that gives enough support. But yeah, in certain instances, we don't have other choice than getting antegrade axis, but not very often.
Well, you know, right here, I feel like I'm in a better plane now than I was before. So I'm trying to advance my fine cross, which is part of the problem. We don't have as much, you know, catheters to try to get into these difficult areas. And this seems to be the most difficult area of occlusion, in my opinion. And I think this is where, sort of like for the audience, maybe like watching paint dry, but it's a very important part of our procedure is the patience that you need to display at this stage.
It looks like you may be in the vessel. It's moving freely, right?
Well, you know, you and I have been outside the vessel, inside the muscle, and you think you're free, and you're not, and you're creating a hematoma. So, you know, I really, as you know very well, I did not want to do that. So I shouldn't be talking. We'll let Dr. Kapoor talk here. Dr. Kapoor, please take over.
So essentially, I mean, it's all like Dr. Krishnan said. I mean, you have to be very cognizant of the fact whether you're inside the lumen, outside the lumen, and of course, with experience, you have a decent idea of how it feels. And you could be freely moving, but you might be in the muscle or outside the vessel versus inside the vessel. In this case, with the roadmap and everything, most likely we are intraluminal, and hopefully we should be successful. But
Well, you know, we got a little bit more to go here, and the wire is not behaving.
So what wire are you using
Right now, I'm
Did
just
you
using
escalate
a Confianza Pro here. Little rail, guys, for me.
So if this
Yes.
doesn't work, what would be your
Pull the
next
wire.
choice?
Rail.
The wire.
Well, I think, like at this stage, as you know, Dr. Wiley, this is as heavy a grade wire as we're going to be able to do, unless we go to 018 systems. You and I have never been fans of 018 systems.
No.
And, you know, in our lab, we really don't like to use 018 systems. But
Have you tried the PT graphics yet? Or
Yeah, I was
not
gonna say
yet.
that.
Not yet. I think in this stage, it's so calcified and so horrible that I think a pedal access may be the only other logical way to go here.
maybe very, very close.
Yeah, that's right.
Yeah, we're very close. I mean, but as you know,
Of
very
course, it
close.
could be subintimal, but
Well,
I'm hoping
subintimal is
that's not the
okay,
case.
as you know. I mean, we can always re-enter down below once we get into the healthy segment. I'm going to try a fielder here, guys.
You get a feeling.
Yep, give me a fielder and give me a sopping wet one. Now, Dr. Wiley, I mean, as far as access techniques for below knee, can you discuss what are some of the access techniques for the vessel below?
yeah, I think that ultrasound guided access is the way to go. You got to be familiarized with the anatomy. The pedal vessels usually course.
Give me a
with
PT graphics as well.
Two veins, so you got to ensure that you're sticking the right vessel and not a vein.
Right.
Most of the times you compress both veins if you're a little unsure, and the one that doesn't compress obviously is going to be the artery, and you get access. Now you could do it with using a Seldinger technique, which you cross the vessel completely in a cross-sectional image, and then you go longitudinal and you probe and pull back until you see the needle coming back into the lumen. Then you advance your wire. Others utilize a modified Seldinger technique where they only get access through the anterior portion of the vessel without going through and through, which is also reasonable. The
Well-
question is then if you put a sheath, if you work sheathless, which I think that's a personal approach that anyone can take. I know you like to go sheathless, to use less profile equipment, and that may be a reasonable approach as well.
Thank you. Yeah, reasonably, we generally tend to go sheathless, as you know. I mean, respecting very much the vessel if we can. As you can see here, we're having a hell of a time getting closer to this vessel. I went with a hydrophilic wire to just kind of push it like an animal, try to break down. As you can see, I'm in an area right now where
Well, your catheter your support catheter is still way back, right?
Well, that's the problem. We're having a hell of a time tracking the support catheter down any further than this. So this may be the area where we are going to have to.
Do you have a Corsair in the shelf?
We're going to have to ask for a Corsair because we are definitely very close here, and it would be a shame to abort here without really trying. The other question is to balloon the track like we do in the SFAs. Give us a little bit of room to get the catheter closer, which is what we may do here. And I think that's what I'm going to probably end up doing. So give me a
pedal axis.
or do pedal axis, but we're so close up and over. I think if I can get the sheet down a little closer, I can definitely succeed here. You know, so I'm a positive thinker, as you know. So you know, let me give it a little bit more chance. Give me another Confianza.
Okay.
And
You're probably not tracking the catheter.
Can I get another Confianza?
yeah,
because of the wire you're using.
Rick, give me a 2.0 or a 2.0 coronary balloon and a new Confianza. So one of the techniques that we've learned is to balloon the track. So yes, you know, we are not perfed outside the vessel. We're following along properly. So what we'll do is we'll balloon the track down below, and then we'll go ahead and use reduce the resistance to push on our support catheter and resistance to torque on our 014 wire. So what we're going to do now here is we're going to switch out for a new wire because that wire is beat up pretty good. And I'm going to make my little CTO tip that my fellow Dr. Purushottam taught me. And then we're going to go ahead. By the way, I want to congratulate Bhaskar to all the audience who've seen him for a year grow into this incredible interventionalist that he's become. He's graduating, and he's going to be going to a great job in somewhere in America, and I don't want to give a plug to that hospital, but they're very fortunate to get him.
But somewhere in America.
Somewhere in America, and you know, I think he's going to be a true leader in the field, and he's going to do great. So we're very, very happy for him. Our entire team is proud of his accomplishments, and congratulations, Bhaskar.
Thank you. Thank you.
So
Dr. Wali, I wanted to ask you a question about, you know, after you obtain retrograde access. So I've heard from Dr. Craig Walker's talk that he always uses a V18 wire to get into the vessels via retrograde approach. So I just wanted to know what is your thoughts on that and how would you approach that?
I try not to use 018 wires initially. I think if I get away using a 014 wire, and we could escalate with those wires, that would be my first approach. My second approach will then be escalating to a 018 wire, but I would not start with that. That's my own personal gestalt. You know.
So what's your algorithm to jumping into a retrograde approach? Would you do it immediately, or would you say give one shot with antigrade and then go retrograde? What would you advise?
You know, I like the approach that Dr. Krishnan and you guys are doing right now. There's nothing to lose by going antigrade. Retrograde is a great approach, but there's risk. If you have an injury or a dissection, or you close down the distal vessel, you probably have not much choices left. You lose a surgical site, and you lose the distal vessel, so there's a lot of harm you can create as well. So I would use it as a last resort, which is what you guys are doing here. You have a single vessel that you're trying to open up. If that doesn't work, he has critical limb ischemia, he has a big hole in his foot, as you guys showed. At that time, I would then use it. But I would never start retrograde as my first option.
I mean, as I said in my presentation, there's not much data, and pretty much it's all observational studies and case series. They really do not have a big number as far as complication goes. So you think it's just a learning curve like how we had in radial artery catheterization for coronaries, that's similarly in
again, you just
pedal approach.
Said the numbers are very, very small. The data's not very, very robust yet. So I would not venture to say that there's not many complications.
And the other thing I always had is, like, you know, for somebody starting out, you know, we see all these different crossing catheters, you know, like the crosser, and then you have the Viance for Infrapop, and sometimes I've seen even the TruePath used. In fact, I think Dr. Krishnan himself did one from below the knee for maybe in a live case, maybe last year or so. So what is your take on that?
I think you got to get good with your wires first before you start using other devices. Good wire technique is successful in most instances. So I don't think that jumping into one of those devices are going to necessarily make the case easier.
Yeah, I mean, I think wire technique is incredibly important. I think a lot of patience is important. You know, realizing the different planes are important. Not getting foolhardy is important. I mean, these are all terms that, you know, we tend to use. And I think one of the good things about us at Sinai, we really let the audience know what we're trying to accomplish and what our goals are. So you can see here that it seems to be going in the right direction. And at the very end, I'm getting into a plane, and I'm not happy with it. Like right here, I'm happy. You see that spot right there where it kind of deflects? But let's see whether this, you know, we get a little bit of luck from, you know, Lady Luck here, and we'll just.
Do you want to take a picture in another angle to see if you're...
Yeah, we're definitely away. You can
Well,
tell.
so-
I'm away. I really feel I'm away. So now at this stage, I think we're all the way down here. We're going to try to get pedal access and go forward. You know, that right there. You see that, Dr. Wiley?
Oh, yeah.
You see
Yeah,
where
I
I'm
think
just...
you're going to a collateral, so...
Let's see whether we're in a collateral. We'll take a better shot of the foot off-road map. Go AP on the foot. Okay, AP. All right. Let's do a road map here.
Okay.
Inject. You see how I'm on top of it, Dr. Wiley?
Yep, yep.
Wow.
See, that's the problem here. So that's one of the reasons why, you know, you have to be a little careful here, understanding your planes and going to different views. And if I keep going here, I'll show you what will happen here. You're just going to get into the other plane. So I think this is a reasonable time to try to stick the foot.
Docile pedis, yeah.
Yeah. So let's do it on fluoro. Let's see how it looks and where I can get an idea here. Just going to use my fingers here, and this is going to be a little difficult, as you can imagine. A little bit of lidocaine.
Is Bhaskar a good sonographer that could help you
Well,
out?
we didn't have the setup here.
Okay.
The reason I'm doing it is just so because we're so close that we can just go ahead and try to get it in and then go. So, but if we do fail, I'm not going to give it too much of an attempt. Is Lido?
Yeah. That's
And
fine.
I'm just going
Give
to
me
go
a
ahead
micropuncture sheet.
and go ahead and you know do
The cook one.
do it on another day. But I may still not fail from above. So I'm just going to bring the needle up to the spot where I'm going to try to stick, which is going to be right about here. So it's going to hurt a little bit, sir. I apologize. Numbing medicine.
The difficulty fluoroscopically
Sorry,
is that it's hard to tell what plane you're at.
So we numbed it up a little bit. Now we're gonna go ahead. Liz, can you knock him out a little bit? So what I'm going to do is, as you can imagine, this is not an insensate foot. So what I may do is I have calcification. I'm going to try to use the calcification to enter. So we generally go with a micro access needle.
Remove all this.
And I'm just going to first place the needle on top and then enter the skin and then try to enter the vessel. Okay. So we got a little bit of blood. I don't know whether that's the vessel or not. So we're going to get a field of wire here.
Right here.
So, you know, I mean,
Of course,
listen,
it could be
guys.
the vein as well.
Well, it doesn't look like the vein, but, you know, who knows? You're right. You know. Like you always said, Dr. Wiley, we're pretty good. We're not that good. Somebody made a what I call as a Bhaskar curve on this one. You know, and with my, actually, I think the only person who has worse eyes than me, Dr. Wiley, is you.
You think so?
Hold this. This is gonna fall. No,
So you say you had some blood return?
We have good blood
Yeah.
return.
Fix your wire. Fix your wire. Yeah. Now it's better. Got it?
Want to lift
Yeah,
your
they-
camera up?
Yeah, look at the camera.
It's not the camera, just the wire is bending. There you go, it's in. Okay, let's floor now.
That's the microaxis wire?
We generally tend to go with a fielder, Dr. Wiley,
Okay.
just to see where we are. And I think we're in the vein.
You,
Okay, give me a little roadmap here.
Roadmap.
Inject. Now, you and I know we're good, but we're not this good, are we? And you and I both know that we're in the vein here.
well, let's see, you know.
See? See, Dr. Wiley?
You are.
See how I'm in the vein? So that's a classic example of getting into the vein, guys. You see the artery and the vein run right next to each other. And you can see that I've just happened to prolapse in the vein. So one of the things that you can try to do is I may be through the artery here. So I'm just going to pull back a little. You agree with that, Dr. Wiley?
Yes. Yes.
So I'm just going to come off roadmap here.
That's where ultrasound is helpful.
Oh, it's very helpful. There's no question. So I'm just going to pull this back a little bit. And I'm going to see whether I can just pop it into the artery. And that's clearly still the vein. Show me above. As you can see, if it was this easy, we'd all be very good, wouldn't we? Look at that. So we're truly in the vein here. And you see how the artery and the vein run right next to each other. You see that, guys? So I'm going to leave this wire there as a landmark. And
All
I'm just
you're going to have when you stick again is that you don't know if
You don't
that
have to
vein is
With a
the
better
lateral or the medial.
Where's the? Given the introduction.
and as you and I
vein
both know, we've
running
both been in
both
both.
sides of the.
We've both been in
the
both.
artery.
So, this is, part of the fun, and part of the challenge of what we do, and not to get discouraged and understand that, the patient is here because he's going to lose his limb, and we're really trying our best to help. So what I'm trying to do is find a better view.
What is your anticoagulation regimen right now?
Right now we're on bivalirudin, Dr. Wiley.
Okay.
So you can see this looks like to me, it's a medial vein to me. So let's do a roadmap right here, guys.
Ready when you are.
Inject.
Yeah, that's the meeting.
Now you see it, guys? You see how close the other wire is to? So it's very frustrating for us as operators when we see these kind of images because you become very depressed. You tend to start thinking and questioning why these things happen to you.
But
But
what's depressed, Dr. Christian?
what's important to remember, Dr. Wiley, is that it's doesn't only happen to you. It happens to everybody who does this stuff.
Is Michelle depressed as well?
So you have a lot of camaraderie in that case. Is Dr. Dangus there? He's my psychotherapist. We work very well together.
He's here right now.
So Dr. Dangus has been very kind to spend a lot of time with me to analyze how I do.
Ray has been quiet back there.
Ray?
Is he depressed as well?
Keep an eye on the needle here, making
Oh,
sure
okay.
there's blood flow.
Anything? Okay, it's very difficult. As you can see, it's like a needle in the haystack.
Top of it, bouncing. Yep.
Looks like the same kind of flow, though. All right, give me the...
What, you think
Don't-
it may be in the other vein?
That's what I think.
Gosh.
So as you know, we both have done both.
Well,
Promise there's a better
let's
flow.
see.
Little dark.
Yeah.
Just support it here. Yeah.
Yep, same vein. All the other vein.
Push it up a little more. Let's see.
Same
Yeah,
vein.
the other vein.
It's the other vein, actually. Okay,
How
we're
about if you hit now the middle between those two wires?
which is what we're going to do, flush this out. I'm going to go for a smaller catheter here. I'm actually going to pull out this other wire. It's actually, I think, creating a distraction for me.
Right. Yeah.
So for those of you who are trying to get good at venous access, this is a great case to show you
Yeah,
that it's not that hard.
you've very nicely demonstrated getting venous access from the pedal vessels.
I'm gonna go RL.
So calcified.
Yeah, it's going to move. Nah. Yeah, that's better.
That's better. Yep, now it's arterial.
You finally got in?
Looks like it. It's flowing like an artery.
Is it red?
It's actually flowing like an artery. Again, the curve is just
No,
wonderful.
it's the new curve.
To be honest with you, it has nothing to do with the curve. It's all the eyesight.
Here, use this. Here, I got it. Give me this.
You still getting backflow?
Okay,
Is the fluoro on or not?
not yet.
Okay. Now it's the magic.
It's probably hitting the.
I'm definitely not in the.
Yeah.
That's the artery. Everybody see it now?
That's the artery. Yeah.
So now we're going to have to straighten this wire out a little bit. There you go. Okay.
With the fine crown.
Usually
Problem is there's not going to be enough purchase to get the fine crossing. Get me the micro dilator in, guys. So
Just
now
about
it's probably feasible.
Could you take
You
the
think we
needle
can? You think we can get the micro dilator through this, or no? You want to try a Confianza instead?
probably
Give me
use-
a, right?
Yeah,
Give me a
I should
Confianza.
try
Give me a
and-
Confianza,
Why don't you
guys.
put a micro,
But
a support catheter and then
I
exchange
think you want to
it
at least
for
leave
a,
it sticking out half.
Confianza.
Well, I'm worried that we're not going to get enough purchase with the microdilator here. So what we're going to do is we're going to go ahead and we could feed a fine cross over this wire. It probably has enough purchase to do that for us. So right now, let me just try to thread a Confianza through with a slight, very, very friendly curve.
You still getting backflow through
Oh
the
yeah,
needle?
we got good flow. I wouldn't say a lot of flow. It's ischemic flow. So again, Ray's
But
rubbed
you don't
off.
think you're in a dissection plane?
Do I think I'm a dissection plane? I think the true answer is I don't know. But again, like I said, I'm a pretty positive thinker. Like you. There you
There
go.
it is.
Show me above, guys. Now, one of the things you could try to do is put this through that micro catheter. So we'll pull back the wire. We'll have Ray just slowly pull back that wire. Give me a torque around this, guys.
Good.
Give me a.
You need
We need
This is
something,
the-
some.
We need a 014.
014
014
torque,
torque,
please.
Do you want to take a picture from above and see the?
I think, like I said, I'm pretty confident we're okay, Jose. I mean, like I said, I think these are the kind of things that you can't be 100% sure. So right now, we're pretty confident. We're gonna have Guy's team, who's our media team here, hold on with us and be patient because I know this is running a little bit over. But at least I want to show you guys the cross. Once we cross, then we can go ahead and do everything else offline and show it to you next time. Let me just, I need a little closer, please. That's great. Okay, let me just see if I can torque this. Wow, it's just zero torqueability. I think, why don't you pull that wire back, Ray, a little bit? Sometimes you hope that.
probably go to my-
Give him some wet ones.
I mean, it's really not even moving. Show me down below, guys. All right, let me just go with a micro catheter here. Give me a 018 Trailblazer, guys.
It's gone. Here. Yeah.
You may also want to use a
Ricky got it
cursor
here.
from below as well.
Yeah, or you know what? Give me a. I like it. I think that's a good idea. Give us a Corsair instead of a Trailblazer. Or you can try a dilator. You want to put a dilator in? Let's
Yeah, I
try,
think
Yeah,
let's
I
try
know,
to put
I
a
know.
dilator.
let's try the dilator.
It was
Let's try the micropuncture dilator here,
okay.
the stiff one. As you can see, these cases take some time. Just have to be a little patient together and work it together. So let's see now.
So if you get through, what would be your approach then? To snare the wire from above or what?
I think if I get through, see now I have the dilator in the vessel. Right now I have a little bit more comfort zone for me. So what I would do now is try to, now I'm going to try to get this vessel. Pull the wire back, Ray, if you can. Give me a, I'm going to need a support catheter, as you can see. Give me.
Have we got the Corsair?
Give me an 018. Now I made a dilator. Give me an 018. Actually, give me the Corsair.
Corsair would be a good choice.
I like the 018 system here because it gives you a little more room. So give me the torquer on this wire.
Yeah, Corsair.
You want to put the Corsair and then put the torquer?
Yeah, but the Corsair won't go through this. Walk the wire back. Walk that back, Ray. Pull the
Because
catheter
if you're
back.
able to bring a balloon from above and one from below,
And just
even
do
if
a
you're
cart,
in
right?
dissection planes, it should open up.
And just do a cart. That's another thing we could try to do. Well, let me walk this out first. I'm going to load the Corsair on. I just wanted to get a little bit more purchase, so I'm a little bit happier with this. Don't pull out the wire, please. Okay.
You made a nick in the skin below?
Nah, I haven't yet. I'm happy with the one ulcer he has. I don't want to create two. Jose, you're not laughing.
I want to see if you're able to get that Corsair through.
And then you'll laugh, huh?
Then I'll probably laugh.
He wants to have the last
You're
laugh.
a funny guy, you know that? I always felt I was
Got the wire?
subintimal in this particular area. So pull, I got the wire. So now is the key. Pull, please. Now,
so far, so good.
rail, please.
You're very close.
Rail,
You
please. So now what we're going to do is, Bhaskar, don't pull too much. You're pulling too much. Okay. Corsair is through. There's our Corsair from below.
The wire's coming back.
I know. This Corsair is slipping in my hand. It's so slippery.
Well, because this is a good sign. If you're up there, you could always then
Okay, good.
advance that balloon from above
Now
and
give
from
me a
the
torquer.
below.
No. Ray, watch this. Your job, Ray, is to watch this. Yeah, so now what we're going to do is we're going to try to torque from below and above. Let me take out this wire, make a better curve. And we can even try it with a fielder wire here. Give me a fielder wire, guys. A new one. So you see, so this is kind of the difficulties of these cases. We got above, below. We got everything ongoing. Now I'm going to make a little bit of more of a torquer.
Yeah.
A torque, just so I can have a little bit more of a ability to torque this wire. And Ray's just going to watch that Corsair. So Ray's like on Corsair
So
watch.
above you have what wire?
Above we have right now a confianza above and a confianza below. You can see Ray's a man who's spoken for. He's got his wedding ring on. Always good. So for all of our fans out there, I'm sorry. Jose, you're not laughing at all. I'm so worried about you. What is going on, Ray? Jose?
Right.
The other thing is to keep the system straight to transmit the torque. Watch out.
wire, yeah.
Can you just hold the wire up
Yeah, I got
without holding it? There you go. Now let's see whether okay, pull that back, please. Keep pulling this thing back. Keep pulling
I
it
think it's
back.
time to take a picture there.
Okay.
Pulling the fine cross back.
Okay, pull the fine cross back. Keep pulling it back as I keep coming.
But without
Okay, I'll
pulling
hold
the
it there
wire.
now. Ray, track the Corsair in. Hold on a second.
Hold on. Let me show you.
Oh, hold that wire, please.
I got it.
Okay, track, push, push.
Pulling the wire from below, that may be a problem.
Well, we're not pulling it yet. We're trying to pin it, and Ray's trying to push the Corsair. It's
Got it.
not
You
going.
screw it in?
There,
Screw it
screw it in. Okay, that's good right there, I guess. But we'll leave it there. Show me above now, guys.
Pan above.
Yeah.
So close. Bit too far.
Keep pulling that back, Bhaskar. Okay, right there is where I think we're going to get in. If I was a predicting man, this is kind of where I like it. Wow. Are we in the vessel? Are we in that thing?
Looks like.
I think you're going to have to ungulate and see
Yeah,
if
get a
we're
different view.
the same
Watch
plane
your
or
knees, right?
not.
Looks like.
Looks coaxial.
Are you holding it? Jumping back, right?
The Corsair, right?
All right. Yeah, we're almost there. Try to advance your catheter card, Bhaskar, into it. See whether you can go in with your catheter alone without a wire.
It's not
Push your
really
catheter.
transmitting.
Push,
There you go.
push.
No, it's on the side.
It's on the side. Okay. Nope. Okay. So I think what we're probably going to end up doing, pull it back, Bhaskar.
Balloon.
Pull back your catheter. I think we're probably going to have to do the cart technique here. Nope.
No.
Oh. Yep. All right. We're going to have to do the cart technique. So let's get the catheter from above and below.
Do you mind describing that technique?
I'm going to have Dr. Kapoor describe the cart technique.
So essentially what we do is we're trying to create dissection planes. So we get a balloon from up and over.
Rail, please, above. Show me
From
above.
from the antegrade side, we balloon it, and similarly from the below side, we get a balloon so that we have two dissection planes, hoping that the dissection planes will open up and the two wires will meet. And then depending on how you want to take it, if you want to go antegrade, we get the wire down into the lumen, balloon, and we're back intraluminal. So essentially it's creating, we have two wires on the opposite ends. We create planes so that the wires can cross each other and come in the same plane, and then we work all along it.
Yep. So now what I'm going to do is, as we get the Cook 018 micropuncture balloon, what I'm going to do is come with the wire from above and try to get into this one
No,
from
the
below.
Cook. There's a 1.5.
Show me. Give me a torque here, guys.
Yeah. Torquer coming.
Here's the torque.
So this seems to be the area, I don't know if we're not hitting it or we're hitting it, I don't know. Like right now, I think that should be the area where we should do the cart technique.
Why don't you take a picture there and see what's going on?
Like over.
Go to another view here. So it's sort of like this particular area,
1.5.
we're going to have to,
Yeah.
I think our wire from above seems to be in a different plane, right? Show me above here. Give me a fielder from below, guys.
You already have a channel from above, so you may use a fielder from above as well.
Well, the point is to try, I think right there we're going off somewhere else, as you can see. See that? So I think the channel from below is going to be easier for us to work with than above. So give me a fielder from below.
Fielder.
Before we go to the cart, I just want to try with a fielder from below.
The curve's not the best. It's the old one.
Give me a couple of wet ones, guys.
Right.
So the other important thing is to keep this thing sopping wet. Duele, are you moving it or he's moving? Huh?
We should take a picture around there so we see what's going on.
Let me torque her.
Yeah.
There's one of the two wires that's taking a wrong course. We don't know which.
Well, I don't think it's below, right?
I don't know. Yeah, I think you got to take a picture at this stage.
But here is all occluded, Jose.
I know, but we don't know if the wire, the antegrade wire, is in the right plane or the retrograde.
Well, I think the antegrade
both.
wire is the problem here, in
Both.
my opinion.
Well, take a picture.
See, this is where the antegrade wire curves off to the opposite side. This is the occluded segment right here. See, that's what I'm saying. So I'm trying to just make some headway with the fielder. If I can track this a little bit down, let me see whether I can track this forward here.
Let me fix that one.
Give me can you show me down below a little, guys? Nah, it's not going. So I think we're an issue here. Give me a comprehensive back from below. So one last time, I'm going to try comprehensive from below. So so if this doesn't work, our plan is going to be to go ahead and do a balloon angioplasty from above and below at the same time, like sort of a cart technique. So we'll do a 1.5 from above and a 1.5 from below, create the dissection plane, and see whether we can break in.
Open up the 215, guys.
Okay.
The other thing I could do is go with an 018 wire from
1.5,
below and try to see whether that can be
Yeah,
enough
give
to
this
be able to
to
get
me,
through.
He wants to use a short one just to do the cart. Yeah.
We're going with an
Yeah.
018 from below before you do the cart technique may be
We'll keep
reasonable.
this till afterwards. But you can open up the buses.
Before you start making dissection planes.
Yeah.
Well, remember, this is an occluded vessel here. I mean, so it's not something, give me a torque enough, thank you. It's not something that I'm very concerned about.
You see, Prakash, right now, one of the two wires is going in the wrong direction, and we don't know which.
I agree with you.
So at this point is where I'll take a picture and try to determine which of
Show me below.
both wires is going in the wrong direction
Yeah, I agree.
before I start
Show me
pushing
below.
more.
So let's leave it right here,
Mm-hmm.
and let's try to meet the wires. I think it's right here.
Yeah, it's just
Right there, it seems to be going in the wrong direction. All right, let's get those balloons ready, boys.
So I got two 1.512s.
Mm-hmm.
Right, here's one. Ricky, can I have another 1.512, please? You got it here, Ricky. It's here. Yeah, second last one. 1.512, yeah.
Now that's interesting because before we were able to get through this area easily.
What wire are you using from above
It's a
again?
confianza.
Confiance, okay.
Let's try from below here. Let's try to get this wire up, see where this one goes.
I need another deflator. Oh, is
Take
it
a
mixed,
picture,
right?
guys, as Dr.
Yeah, he's
Molly's
done it.
saying. Ready?
Should be okay.
DSA. Ready?
Hold on, 1 second. Yeah. No. Just come on. Yep.
Inject.
Inject it.
Looks like a bottom wire is dissecting. Agreed?
It may be both, but I think that now you could consider using the cart technique. And hopefully when you create those two dissection planes, you meet up.
Show me both.
both wires.
But I can't understand why I can't get the top wire into the plane, Jose. It's really bothering me.
Why don't you bring down your support catheter and see if that helps you?
I did. Show me above. Let me make a better curve here. Give me a better curve. So while you guys are watching, I mean, the other techniques that you can use in these kind of things are the cart technique. The other techniques that you can use are, what are the techniques that you guys know of breaking planes? Any other technique?
So can you use a re-entry device like an end tier below the knee and try to poke into the lumen? Does that help?
I mean, you could try. I think at this stage you've got below access, above access. It's a true limb salvage case. It's very difficult to say. I think, we're going to have to see whether I can get this down. We seemed to be in a better plane long time ago, and now it seems like it's forever, but I'm not going to give up yet.
I agree. I still think that if you advance a balloon from above and from below, even if you're in dissection planes, those wires will meet.
I think we're definitely going to advance the balloon, Jose, where there's no question. I just want to see whether we can get this a little bit in a little closer, like where the balloons were where the wires were kind of on top of one another. Remember below? Now I think I'm going to need a fielder here.
You got a feeling?
Right there is the problem.
Why don't you try a PT graphics from above?
All right, give me a PT graphics, guys.
We need another one, guys.
Show me above again. We try to come from above.
Yes, please.
Well, we're confident that right now you're in the vessel. It's somewhere from here to the other wire that you lose course.
Right there. I think our only hope here is
Then bring down your support catheter and exchange it for a PT graphics, and see.
Yep, but I think I might have to do like a loop wire technique or something here, Jose.
Yeah, that may be okay.
Huh?
And that may be okay.
Yeah, that's what I'm saying at this stage. I think I might have to loop my wire, which you and I generally don't do.
Right there.
See, that's way off now, man. Right? Pull this wire back a little, guys.
The other one?
Yeah. Keep pulling it back.
Yeah, but I think it's off course from
Below.
above now.
Yeah, we're way off from above. Yep. Yep. So is it even worth doing a cart technique now?
I don't know, you got to take a picture again and advance your wire from below and see where you're at.
Yeah, this is where we're running into more problems than we thought. Flora?
Ray, Flora.
pull this back a little, Ray. Maybe this is in the Flora. Come down now. Show me down.
Yeah.
Flora. I got it, Ray. Don't worry. Oh, Ray, support on the catheter below. Show me down. Don't push it, Flora. Just don't push it, just support it.
Oh, it's kicking back.
Oh, it's kicking way back.
Whoa.
Show me down. Okay, good. Don't push it yet.
It's kicking back.
It's coming back.
Is
Hold
the
on.
catheter kinked or something below?
No, it's not kink. Let go. Flora. I'm just trying to get into a different plane here, and we're basically losing the catheter here. It's almost out of the vessel. Okay. Show me above now.
Who's doing it?
You're still with your confianza from below?
Right.
Yeah.
Why do they need it right now?
So what I did was I changed my plane from below a little bit, and right here it's starting to go somewhere else. You see that?
Yeah, well, again, we don't know now which is in
that's
the
a little
correct
better.
plane. So unless you image again, we're guessing.
Well, I'm not exactly guessing. No. Now we're in another plane. It's so funny. We got so many planes from below and above. That's another plane. That's another plane. I think we got to trust that from below we're in the right plane. Pull that other wire back, guys.
It's coming back.
Oops, it's coming back. Okay, hold on.
Then go ahead and
Show
balloon
me
both tracks.
I think here we're pretty close.
Got it?
Yeah. Show me above. Above. Show me the catheter. Lower, lower. Our catheter is basically out of the body. Show me above now. Above. Okay, Ray, walk your catheter back now. Slightly. Walk your catheter, Ray, more, Ray. More, Ray. Leave it right there,
You
Ray.
guys losing the wire again.
No, we're not losing the wire. We're just walking the catheter back here. Let me see this. Bhaskar, can you put some pressure on this thing for me? Keep walking it back, Ray. Right there's good. Keep walking it back, Ray. Show me above. It's just slightly, Ray. All right, now bring your wire, pull it back more, Ray.
Can you bring your support catheter up?
Yep, we're going to. Okay. Yeah, look at. I don't think it was going anywhere. Oh, it's going.
Show me the tip.
Wire's okay. Don't worry about it.
That's the Corsair.
No, the Corsair is not going any further. So I think right now we should decide where we want to do the cart technique. I think right now we are, where's my, okay, we're right there.
Can you advance your wire a little more?
We can try.
You still need to have overlap of both wires.
Now advance the other wire from the other side, guys. Okay, give him a fielder from the other side. We're just dissecting the vessel. You see that? See that, Joe?
Yeah, I think so.
Well, I definitely agree. That's it. Go. That's it. Right there, Jose.
I think that's a perfect place to do it.
That's a perfect place to do it. Let's just check in multiple views. Yep, we're on top there. Look at that.
Go for it.
You know what, Ray, just do me a favor. Let's try something here.
Yeah.
Just because I'm a little ambitious. All right, get the balloons ready, guys. Get a coronary 1.5. Stay there. Nope, right by the side. You see that?
That's
So,
okay.
All right, let's get 2 coronary balloons.
Mm-hmm.
I'm just going to advance this. Loop that there.
Good. It's good you have a knuckle there.
Yeah, I'm going to just leave that as a knuckle. Hold this.
Got it.
Feel his calf, Liz, for me. Okay, ready?
You have the wire?
No, not yet.
Got it?
All right, so we're going to go from 1.5 above on the fielder. So right while they load that up, I'm going to have Bhaskar walk this one out. Go ahead, Bhaskar, just walk it out.
So you're hoping to be able to track the balloons.
Wait, hold on, let me straighten it out. Hold on. Well, slow me down.
Mm-hmm.
Slow me. Okay, walk it out.
Did you ever make a nick in the skin or you didn't?
We didn't, but we will. Okay, it's out now.
Okay.
So we're going to load the 1.5 from below first. I will.
Yeah, I'm very confident that after you balloon them, the wires
I'm glad you are, Dr. Wiley.
will meet. I think you're as close as you're going to get. And,
We're just teasing here. So for the audience, as you can see, the difficulties that we have. Whoa, 1 second. Okay, go. Let me make sure I have the balloon in my hands. The wire. So we're going to go with the cart technique, above and below. Okay.
The wire.
These are monorail system, correct?
Yeah. Don't lose that wire. That's the key.
Let me see the top.
See, this is a question where I think a sheath would help us. But I'm just a little concerned, obviously. I think an over-the-wire system might be easier to push. Don't you think, Joe?
If the balloon doesn't go, you could always try to use a 0.9 laser.
From below, right?
From
But
below.
I wouldn't do that till I'm in the lumen, though.
Of course. Well, I mean, we're hoping you're in the
Okay,
loop.
let's walk this one out. Careful, because I'm gonna have to put a sheath in this one.
Start pushing up.
Or we can try an over the wire.
You want to try the cook over the wire 1.5?
Yeah. Give us the cook over the wire 1.5.
You know, theoretically, an over-the-wire system has more pushability, but most of us who
Or we
use
could
a monorail system, you know, I think that sometimes you could do a better job with them.
We're going to try the cook over the wire from below.
20 millimeters.
It's a 20 millimeter balloon, which is fine. Got a much stiffer pushable shaft, I think. Yep, definitely.
So do you always use long wires when you do these types of interventions, or
Well,
you
in general, we like to use longer wires. I think gives us a lot more options. So we'll see. We'll see whether we can get this up there so you can see all the channel. Don't pull it. Just do very slowly. Ready? Rail? A little more rail? You're not railing?
Yeah.
Still not railing? Still not railing?
Maybe a neck.
Hold on. Okay, rail?
Here, let me give you more.
Okay. Rail?
Rail.
Nope, you're not railing at all. No, it's an ulcer. Okay, I'm in the vessel now.
Guys, where's the balloon?
We're trying to track it up. It's not tracking.
Now it's gone.
Why is it so tight? Show me down below. So you can see we're having trouble at the incision site. I think we need to put a sheath, don't you?
Yeah, you could put a sheath, or you could go with a.
Try one more time.
That's a trail.
I know 1.8 Trailblazer
it's-
probably will not track.
It's just not going. So we need to put a sheath. Walk it out.
Have the cook forefront sheet.
Yep.
You think that a 0.18 Trailblazer would go up?
We can try. Let's give you an 018 Trailblazer before we switch to the sheet. But can we use an 018 wire on the sheet?
On the forefront sheet?
Yeah, you should.
Actually, let's just try to put the sheet in. Give me the sheet. There's the dilator. Give me the sheet.
No, it's the whole thing.
Oh, there's the whole thing is a sheet. Okay, good.
Now, where's the dilator of the sheath?
It's inside.
Comes with it.
One second. This wire is a little tattered here. Show me down, guys. Now rail me, please. Pull the wire, actually. You're going to have to pull the wire. Don't worry about it.
It's coming back quite a bit.
You can see the wire is totally messed up, Jose.
Mm-hmm. I'm having trouble now.
Wow. Nope. Walk this out. So we're going to change out give me an 018. Yeah, well, I don't even think that's the problem
You're
here.
going to have difficulty even putting a dilator in alone.
Or probably put a dilator, switch over to a new.
Yeah, give us a
Exactly.
dilator.
There's a stiff, get this on, get this stiff dilator.
I think it's already 30 minutes advanced, guys. What do you think, Jose? We should stick with it for another 30 minutes, or what do you want to do?
I mean, you're so close. Why not?
Okay.
I think it's important to see what.
Yeah,
what are
we're
the
just
different
having some
options.
technical issues with the dilator and the sheath and things like that, which are expected in these kind of cases. So what I'm going to do here is switch out and probably change my wire too to a better wire.
So you've already made a track, so perhaps putting a support wire would be the way to go, so you can advance then a balloon.
Pull the wire, please. Pull the wire. Don't worry about it. Keep pulling the wire. Keep pulling. It's okay. Keep pulling. Even if you lose it, it's okay. There you go. Good. So we're in the vessel now with a new dilator. So now I need a new. Now I'm going to go with. Can I put an 018 wire through this? No, right?
No.
So give me a. This is just the dilator. Give me a new. Give me the micro access wire now. The access wire from the Cook sheath. Okay. We need to put a sheath now for sure. So we're going to put a support wire. Well, this is the one they give you for the sheath, right? Yeah. So this should be fine. Wow. Yep, not gonna work. Give me a new Confianza.
You know, if you have a track, perhaps a mailman may be helpful.
Yeah, but that was not at all torqueable. So right now, I think what we're going to do is we're going to struggle here a little bit. So I think let me outline the case for you guys. I know that we're not going to be able to show you the whole case, but I think clearly what we've done is we've got dual access, and our plan, which we will succeed, is to go ahead and get a wire next to like the other one like we had, put a sheath in, and then do the cart technique, and then go ahead and angioplasty this particular vessel, and then be able to get back in. So you can see now we're going to go with an 014 wire, which is right there. So we got bent to a better plane, right? So now what I'm going to do is give me a torque around this, see whether I can just advance this up to where we were. Show me above. Oh, that's not where we were, that's for sure. That's more like where we were.
That's still okay.
It's okay, I'm not saying it's not. I mean, just saying that it's not exactly where we were.
So you have a dilator or you have a sheath?
With the sheet.
I think we might be in, Jose.
You may.
Ray, pull out that wire a little bit. Actually, track your catheter down.
I have a balloon on. There's no catheter.
Oh, you just have a balloon?
Yeah.
So the question now is the way this wire is moving. Are you impressed, Jose, or no?
I mean, I think you have multiple dissection planes. I think you're still going to have to end up doing a cart technique.
Nothing wrong with this.
Now you have a sheath below, so why not advance the balloon and go as you had planned?
It's coming back up now, right? Okay. All right, I guess you just had a PVC. So the question now is, should we get a sheath from below now?
I would. That's what you were trying to do.
Yeah. Okay, so let's advance this a little bit. Okay. Now give me a Cook wire, please. I'm going to take this out. Mm-hmm. Micro access wire. Get the sheath ready, guys.
With the dot.
I'm not sure if that access wire is going to go up easily. Oh, it is.
Okay, that's good enough for us
Yeah,
there.
for you sheath.
Now that I've dilated it, now I can put my sheath. Not get us the balloon, the wire and balloon on this side, guys. Wow. I think we're in enough, right?
You know, I would advance a little more if you can to take off that bend out. So
Actually, no, give me a new sheet, guys. I bent this sheet.
what size is that sheet? 3.3 French or what? Vishal?
It's a 4 French.
4 French.
This is which sheet is this?
Cook.
The cook again. Did not bend it this time, hopefully.
So can you advance a 1.5 balloon over the sheet? Sure you can, right?
Should be.
That's much better there. And now give me the.
All right, let's get the. You want the confianza?
No, give me the this thing. It's not bleeding, so that's fine. All right, so give me the balloon and the confianza.
Yeah.
So now we got the sheet in. Where's the wire tip?
The other right. Nope, the other side.
So if you're looking for pushability now, why not using a command wire or a mailman wire that has more support?
Well, because I need to get back up to that plane, right?
Yeah, but you have already a track.
Well, I don't know. I'm not confident enough to say that a command or a mailman will get me there. So let me get up there first again and then switch with an 018 wire and then be done with it. You know what I'm saying?
Mm-hmm.
That's my thought process here. So now with the sheet, this should be much more torqueable. Show me.
Yes. Wow.
Looks like we're right on top of it there, Jose.
Yep. You know what? Try with your balloon. It may go.
All right, give me the balloon, guys.
You want over the wire or the coronary?
I would go with the over the wire.
You work closer with the over the wire or the monorail?
I think both sucked.
Both what?
Both were not good.
Okay.
Mm-hmm. That's fine. A lot of resistance, Dr. Wiley. Nope.
Okay, breaking the cap.
I mean, it's just being, the balloon is just being destroyed.
What
Nope.
balloon is that?
It's the Cook balloon. All right, give us the coronary balloon now.
Yeah, get a coronary balloon.
Walk this out. I'm holding the sheet, don't worry.
Just get a
Where's your
I'm just thinking.
coronary monorail balloon and
No, I think you need a new one.
One new one?
Is that bent? It looks bent to me, right? No?
No, it should be.
No, it's not bent.
right now you need a low profile balloon to get it.
Yeah,
up
we have a
there.
1.5.
Ricky, and
coronary balloon?
Yeah.
Ricky, no.
It's actually the mini truck is what I like better than this
Okay,
one.
good.
Mini truck.
The apex push also.
You
Probably
got it?
have to advance the wire a little more. 'Cause there you go.
The wire's bent again here. Show me down below. There's the balloon. Not almost.
Jiggle it.
Nope, bending.
Are you getting close?
Nope, it's bending. I go.
As we say in the Army, you're so close you could taste it.
Show me above. The question is, am I just in the vessel now and I can just try to, I'm not balloon it from above and try to just snare it, you know?
Well, we're not sure.
Do me a favor, fix this sheet, walk this out. It's all bent. Give me another wire, guys. We got to stop bending the wires. Let's go. Pull the whole system out. No, you got it. It doesn't matter. The wire's got to come out anyway. We got to do it again because the wire's gone.
Can you guys stop bending the wires?
Yeah.
Trying our best.
Give me a Corsair from below now. Let's try Corsair through this thing with the sheet.
If you get a Corsair, you probably have to then exchange for a support wire.
Yep, that's exactly my
Use
point.
a mailman or command or whatever you feel more comfortable with.
Exactly. No, we got a Corsair. I don't know why Ricky's running out. Ray, you want to go to room 4 now? Oh, Dangus, right. Dangus is in 4. So room 5 is normal? Yeah, that's fine. No, it's okay.
Are you guys wetting those wires? I see a lot of difficulty trying to, yeah.
No, they're sopping wet. They're just all bent.
We're soaking wet now.
You got it? I got the wire. Hold on. Okay, rail. Mm-hmm. Great. And just give me a true rail, please. Give me a dry one.
Mm-hmm.
Pull the wire, please. That's good. Pull the wire. Uh-huh. That's great. Keep going. Great. So far, so good. A little more. Just a little more. All right, give us a new wire. Let's try to advance this with a new wire. Give me a new Confianza. If you can't lie flat, how are we going to do a cat? That's the question, right?
What's your ACT?
ACT is on bivalve, 3 something.
Okay.
So you see the difficulty for the audience from below. I mean, we've got a sheet thin, ACT's high. We've given our usual cocktail here, and now we're in this. We're here below, and now I'm going to try to just advance this a little bit.
Oh gosh, is that wire moving freely?
I don't think so, Jose.
No?
I was thinking
Okay.
the same thing, but I don't think it is.
Okay.
As you can see, this Corsair, I'm going to have Doctor pull back the wire a little bit as I advance the Corsair.
Give you a little rail.
Yeah, pull back the wire again.
Uh-huh.
Okay, it's back, so let me push it up again. Give me a torquer on this thing.
Yes.
Ray, pull back your wire a little bit. Let's just see if this wire is moving freely. Yeah, just pull the wire back. Yeah. Uh-huh.
You have a nice knuckle there. You don't want to lose it.
Yeah, I know. We're not going to lose it. That seems to be moving pretty freely right there. You see that?
Yeah. Well, advance the Corsair and get a supportive wire and let's advance the balloons.
That's what we're trying to do. Pull the wire.
Yeah.
Oh, my goodness. No way. There's no further this thing will go. So now give us a grand slam. Let me see if I can advance a grand slam through this.
You're going to advance your Corsair a little more?
That's all I can go, Jose.
No, it doesn't go anymore?
Doesn't go anymore.
So then you have to advance your antigrade wire.
Advance the antigrade wire down, Ray. Advance it nicely. Advance it. Advance it. Advance it.
Do it here.
Right there.
Very nice.
That's probably good enough.
Mm-hmm.
So get us a mini truck, guys. 152.
Oh, there it is.
Okay, walk this back now.
Mm-hmm.
So a very supportive wire up top. Now we're going to walk out the crosshair. That's fine. Don't dissect too much up top, please.
Okay, we have 2 knuckles.
This is very safe. Okay, you're out. Now let's get the 1.5 balloon from below, which is where we're having all the trouble. So hopefully this little Corsair made a little channel for us to get this balloon up now, which is the hope.
And now you have a supportive wire, so.
But even then, hopefully we have a nice knuckle. Yeah, I just want to go really slow.
Sure.
Bro.
Mm-hmm.
I think part of the problem with the coronary balloons is the shafts are not stiff enough.
Well, you've gotten through that cap that was giving you difficulty before.
Yeah, but I just really want to get to the point where the two of them really overlap, which is probably a little bit higher, but I can't get it any higher here. That's about as high as I can go.
Well, let's get the other one from above. Then.
Yep. And get the other one from above. Give me the wire. I'll rail you. Okay. So I'm railing Ray here. And from above, hopefully it's a lot easier. Is it going? No, not yet.
Yes.
You'll see it. Don't worry, I'll tell you when I see it.
Yeah,
There
yeah.
it is. Keep coming. Keep coming. Keep coming. Keep coming. Keep coming. More, 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 more. Right there. Now push your other wire a little down, your support wire down.
You want to overlap that balloon a little more.
Push the wire down more, Ray. Good. Now bring the balloon back, Ray. Your balloon back. More, Ray. Bring the balloon back more. Balloon back, Ray. Balloon back. Yeah, more. Right there. Good. Okay, 2. So this is going to be the cart technique in the leg.
Even if you overlap a little more of those balloons, it's not going to be a
No, but that's
problem.
overlapping right there. You don't want to overlap them?
Yeah, I do.
Then
Oh, okay. That's,
you see the 2 dots, don't
yeah,
you?
yeah, I see it now.
Yeah.
Let me know.
So we're just going to go up together, right? All right, go 1,
1,
2,
2,
3, 4,
4.
5, 6. So there's 2 balloons in the leg. Okay, down, go up again.
Did you guys put any contrast in the balloons?
They're, well, you know, the
Wow,
usual. They're very small balloons, so they'll come up now. 2, 3, 4, 5, 6. Okay, again, down. All right, so what do you think now, Joito?
Well, let's hope that we've communicated both channels.
Okay, now we're going to walk this one out from below. And we're going to try to re-enter from below. I think that makes the most sense.
You can start right there.
Huh?
You can start there. I don't think you have to pull
What?
out that much.
I couldn't hear you.
Yeah, I would not pull back that too far out.
No, I took the balloon out.
Okay. It's monorail. That's
Yeah.
correct.
So now I'm going to go with what is it called? A fine cross, or yeah, give me a fine cross now, guys. Fine cross,
Can I get
please.
another fine cross, please?
And then you're gonna have to change your wire.
Yeah. Now I'm going to change the wire. I'm going to keep the other balloon as the area where we dissected it, and hopefully we pop in here. So for the audience, I mean, you've seen, retrograde access, you've seen antegrade access, you've seen multiple wire techniques, and at 10 o'clock we're going to stop. I mean, because I think it's 2 hours. I think we've extended our time by 1 hour for this difficult case. So if we don't get in by 10, we will cine everything, and we'll show you the case in July.
Yeah, it is not rare for these cases to take well over 2 hours.
Well, no, I think it's
think,
expected. I think these kind of cases
I think
are
where you're at
expected.
is actually.
Yeah, especially when you're now going to cart and so on and so
Very good
forth.
time,
And this
yeah.
is part of the reason nobody does them live in the conferences.
I got it.
You know,
Have the wire.
so real. But I think the concepts are important for
Well, the
the,
symposium showed a very nice case you did.
but I think it's not to this detail because you can't, obviously, because of the difficulty. Okay, well, take the wire out now.
Of course, you didn't do cart or anything like
Give
that.
me a
but
Confianza. New one, guys. So I'm going to make a little curve on this Confianza and hopefully poke into that dissected plane. The other thought maybe is why not
a
try
fielder may be better.
Fielder? All right, give us a
Yeah.
fielder. Actually, I have a fielder here. Is he okay, guys? That's fine. We'll go with the PT Graphics. It's a hydrophilic tip, so
So is this a fielder or PT Graphics?
PT Graphics. So it doesn't want to go there.
Probably got to pull back.
Pull the
the
balloon
other
back?
balloon, yeah.
Pull the balloon back right all the way.
Looks in the
Oh, it's definitely not there, Jose. Nope. Nope. That's definitely not it. Show me above.
It's moving pretty freely now.
I think we're in the vein. See that? We punctured into the vein. This is the area. Let me track this up here. Rip.
Okay.
Up to there, I think you're in the vessel.
Huh?
Up to there, I think you're in the vessel.
Yeah, that's why I'm just tracking this up a little bit. Let me give me a confianza here, guys. Walk this out. We got it. So we've got another 5 minutes to work our magic. Hopefully we can show you across here before we're done. You can leave it there for now, just in case we perfed or something. Show me a little lower, Ray. I mean, I got it. Ray, pull your wire back now. Keep pulling your wire back. More. Leave it there. Torquer.
I gave it to you.
Oh, yeah. Thanks.
Pull your wire back, Ray. Wire back, Ray. Let me come back down. Show me down.
Right on.
Boss, you go on the other side and load the fine cross on that wire. Show me above. Fine cross. We have another fine cross.
Ray had it.
Nope, definitely not. I think we're about done here, Dr. Wiley.
Yeah, we're almost
I
there.
don't know what else to
so
do here, so I'm going to keep trying offline.
You're going to have to work again from above
above
and
and
from below,
below.
see if you match those.
Yeah, so Jose, if you
Those
can
wires.
give the audience a kind of a recap on what we're doing,
Sure.
and then sign off, that would be great. And I'll just work here,
Okay.
and I'll do it from here as much as I can.
Okay, sounds good.
So I thank everyone for coming, and thank Dr. Kapoor. It's such a difficult case. Can you put some pressure on this wire, on this thing? And we'll see how it goes, and we'll hopefully give you good news when we see you next.
Thank you so
Thank
much.
you, guys.